All right. So I have the pleasure of working with Nataliya on a regular basis. She's an associate professor within the Division of Rheumatology at the University of Ottawa and the director of the Rheumatology Training Program. Her areas of interest, both clinical and research, include a variety of vasculitides. She runs the Ottawa Hospital's vasculitis clinic since its establishment in 2011. And is doing some fantastic work in assembling a cohort of patients with aortitis with whom she has already had a number of fairly impactful publications. So I'm going to turn the floor over to Nataliya, who's going to talk to us about inflammatory aortopathies and sort of an update and what we're thinking about today.
Thanks so much for the introduction, Munir. So I'm going to see if I can share my screen. Here we go. Okay, is this good?
That's perfect.
Yeah, awesome. Great, so I'll go right into it. I don't have any disclosures that are relevant to this presentation. Basically, I'll be talking about some definitions and classification, workup of patients with suspected or confirmed inflammatory aortopathy, approach to therapy and monitoring, and then I'll talk in a little bit more detail about the two most common causes of inflammatory aortopathy, GCA and Takayasu. So in terms of definitions, so there is a distinction between two types of aortopathy in my mind. Aortitis is inflammation of the aortic wall. So it's a type of vasculitis, which is really my main area of expertise. And then there is periaortitis, which is inflammation around the aortic wall. It's actually a subtype of retroperitoneal fibrosis, which is sort of inflammation and fibrous tissue in the retroperitoneal cavity. It's not actually a type of aortitis. It can be seen in combination with aortitis, but by itself, it is a different entity. So in terms of presentation, so aortitis often is asymptomatic with increased use of imaging for various indications. I certainly get a lot of referrals of, where aortitis or large vessel vasculitis is found incidentally on imaging, and usually that looks as increased thickness of the aortic wall of at least 3 millimeters. Or sometimes increased uptake on MRI or PET scan. And then sometimes also I get referrals where pathology from, histologic assessment of an aorta from a surgery reveals unexpectedly presence of aortitis. So there are symptoms that are related to structural issues. So obviously like aortic aneurysms, not really asymptomatic, I suppose. And then sometimes stenosis, and that can cause claudication, dissections. And then when the actual aortitis is symptomatic, sometimes patients have some kind of dull pain in the abdomen or in the back, or they can also have constitutional symptoms from kind of systemic inflammation. Periaortitis actually has very similar symptoms from the actual inflammation area. So also dull pain, constitutional symptoms there. Inflammatory markers often are elevated, but the inflamed fibrous tissue also tends to obstruct structures, most commonly ureters, causing obstructive uropathy, and also duodenum, sometimes inferior vena cava. So those are kind of separate symptoms. And then in some cases, periaortitis and retroperitoneal fibrosis can be asymptomatic, and then that is most commonly identified on imaging. So in terms of causes, so this part is about aortitis. So I thought to discuss the different causes of aortitis, the best way is to look at all the different types of vasculitis. So this is the most up-to-date way that we classify different types of vasculitis in rheumatology. It's not actually that recent, but certainly the most up-to-date way. So by far, the most common causes of aortitis are the true large vessel vasculitides, Takayasu's, and giant cell arteritis, which is not surprising. Aorta obviously is the largest vessel of the body. And then other types of vasculitis can be associated with aortitis. The ones that, variable vessel, more common. But in general, those are much less frequent than the large vessel. And actually, perhaps more frequent than those sort of not large vessel vasculitides would be seen aortitis in the context of systemic rheumatologic diseases. Rheumatoid arthritis is fairly common in my opinion in my studies as in general, and then others would be like polymyalgia rheumatica, I think relapsing polychondritis. Anyways, pretty much all of these conditions can cause aortitis. In terms of secondary causes, so syphilis is the classic infection that can cause aortitis. Tuberculosis is quoted. I think it's pretty rare nowadays for that to cause aortitis. Out of cancers, I've seen some hematologic malignancies causing aortitis, like lymphomas, leukemias. And then this actually is a condition that is of particular interest to me. It is quite different from all the other conditions we've spoken about so far, because all of those ones are systemic, and this is in the category of single organ vasculitis. So as the category name suggests, the process is limited to the aorta. There should be no symptoms outside of the aorta. There shouldn't be any sort of systemic symptoms and no evidence of systemic inflammation on blood work either. So really kind of a limited condition, and obviously approach to therapy is slightly different because it's limited. That was etiologies of aortitis. In terms of etiologies of peri-aortitis, which are sort of the same as etiologies of retroperitoneal fibrosis. So the classification, you will see that there's much less publications on peri-aortitis compared to aortitis. The best one I found was from 2007, so quite outdated, but I thought it was a good summary. So 70% are referred to as idiopathic retroperitoneal fibrosis. I think the better term would be inflammatory, because those are the primary inflammatory conditions causing retroperitoneal fibrosis. So 35 to 60% are due to IgG4 related disease, by far the most common. And then other inflammatory conditions, like pretty much all of the ones that I named when we talked about aortitis, can be associated with peri-aortitis as well. And then the rest are secondary to infections, malignancies, drugs, and some sort of trauma, radiation, kind of more mechanical issues. So I actually when I looked for where aortitis and inflammatory aortopathy comes up in cardiology literature, I actually found the same AHA guidelines. I'm very reassured that those are the ones that Julie was quoting as well. So aortitis comes up in the discussion of thoracic aortic aneurysms, and it lists basically different causes, and one category is inflammatory aortitis. It only lists several of the conditions that I discussed, and in the text there are a few more that are mentioned, but certainly there are others that can cause aortitis, so kind of beware of that. And then in the discussion of abdominal aortic aneurysm, the statement is that inflammatory aortitis is a rare cause of abdominal aortic aneurysm. I certainly have seen a AAA as, in association with inflammatory condition, but obviously it can be unrelated potentially to inflammatory condition. And I think relatively, like, it's so common by itself that I think that's a fair statement. I actually didn't find anything about peri-aortitis in that document, and that's not surprising, because in general, I think peri-aortitis there's much less kind of talk about it. Approach to suspected or confirmed aortitis. It's really my approach, because I don't think there's guidelines about aortitis in general, because that kind of encompasses many different conditions. So the first step in my mind is to look for an associated condition to decide what is the actual diagnosis. Obviously, to do that, we do history, physical, and do investigations. I think these are reasonable infections to rule out. Inflammatory markers are very helpful to differentiate between systemic and localized disease. Then serologies based on which conditions you suspect. For peri-aortitis, because IgG4-related disease is such a common cause, I think it's reasonable to do workup for IgG4-related disease. I mean, I think you can also refer them to do that workup, but the usual sort of markers of disease activity would be IgG4 level, eosinophils, IgE, and complements. And then other tests based on which condition you suspect. If there is something to biopsy, like a swollen lymph node or inflamed, I guess, lymph node, to help you the actual underlying diagnosis, obviously that can be sought as well. And then the next step is to assess the extent of vascular disease. So usually we are referred because like they find aortitis in thoracic aorta or abdominal, but it's very important that we have the whole length of the aorta and the branches image so we know what, how extensive this disease is. In terms of treatment of, first I'll do treatment of chronic peri-aortitis. It is a little bit, I think, simpler. So most patients require therapy just because of the symptoms that they have, like systemic inflammatory symptoms or pain or obstruction of the various organs. So in addition to obviously relieving the immediate obstruction, which is sort of done surgically, usually patients are treated with high-dose prednisone. Pretty much everyone with any kind of inflammatory condition is treated that way. And usually for peri-aortitis, we just start with prednisone and then, see how they do. And then if there's incomplete response or if they flare as the prednisone is tapered, then we think about adding additional treatments. Inflammatory abdominal aortic aneurysm is a subtype of peri-aortitis where the inflammation is just limited to around the abdominal aortic aneurysm. If the patient is symptomatic with pain and like evidence of systemic inflammation, then treatment is reasonable. But if they're not, I often will just monitor them. For aortitis, it's a bit more complicated. It certainly does depend on the cause. Well, sort of it does for peri-aortitis as well. Isolated aortitis often doesn't require therapy, especially in a setting where it's discovered on an assessment of pathology of, let's say, a resected area. So the theory is that the resected segment of the aorta, the resection is the treatment in a sense, and presumably there is no ongoing inflammation left over in the body. For systemic aortitis, if there is a defined systemic condition, then we treat it according to those guidelines, and otherwise we just do high-dose prednisone with or without steroid-sparing agent, like for everything else. I'm not sure how I'm doing with time, but so at this point, it is quite difficult to talk sort of in general about workup and treatment of aortitis in general, because it is somewhat of a heterogeneous disease. So GCA and Takayasu are the most common causes of aortitis, not as much peri-aortitis. And those are the two conditions that come up in the AHA guidelines as well. So these are the diagnostic criteria that AHA guidelines give. I should mention that they're actually not diagnostic criteria, they're classification criteria, which are supposed to be used for enrolling patients into clinical trials and not for diagnosing of all comers. And these sensitivities and specificities are for correct classification, not really diagnosis. I will say that they are used for diagnosis, or at least to help with the diagnosis. And I think as long as they're not just used bluntly with, okay, 3 criteria met, that means the patient has the disease, obviously, like using that in the clinical setting of where you suspect this disease in the first place, I think that's still reasonable to use them. The one thing I should mention is that the giant cell arteritis criteria, so by the way, these criteria are from 1990, so they're quite outdated. The GCA criteria are largely aimed to diagnose cranial giant cell arteritis, where patients have headache. This used to be called temporal arteritis. Now we stay away from that term because it doesn't encompass all of giant cell arteritis. There is an updated version of those criteria, which actually add presence of large vessel vasculitis by meaning like CT, MR angiogram, or any kind of vascular imaging or biopsy to those criteria. So that basically expands the definition of giant cell arteritis from just temporal arteritis to sort of pretty much all large vessel vasculitis. So with this expansion, pretty much everyone with aortitis who is over 50 and who has evidence of systemic inflammatory response can be called giant cell arteritis. And with that, the implication is that now very few patients, especially older patients, end up being called idiopathic aortitis because we pretty much can classify them as giant cell arteritis most of the time. That does help actually, get them on proper treatments as well, because they are supposed to be called GCA before they can get some treatments. I should mention that the classification criteria for giant cell arteritis and Takayasu's have been updated. These are 2022 classification criteria. They're also classification criteria, not diagnostic criteria, and they are designed in such a way that they're a bit more awkward to use as a diagnostic criteria because they are more complicated. They also give weighted scores. So I do think that they improve the accuracy of classification for clinical trials, but unfortunately they won't be particularly useful for, assisting the diagnosis. But so you're aware they're there. And this is what the AHA guidelines have about GCA and Takayasu. I will say that I was quite impressed that the way that these guidelines summarized our pages and pages of guidelines, which we have for each of these diseases. I think the key elements are all here. So, I was just going to go briefly over them. So this part is pretty obvious, and I've stated that many times, just says that whenever we suspect large vessel vasculitis or aortitis, patients should have imaging of the whole length of aorta and vascular tree. The treatment of both GCA and Takayasu includes high-dose prednisone, as does treatment of pretty much any systemic inflammatory condition. And then this part talks about the fact that we generally use another agent in addition to prednisone for both of these conditions. For GCA, the most effective agent is tocilizumab. There's actually a well-designed randomized trial that shows that tocilizumab decreases flares and decreases prednisone requirement in patients with GCA. And then for Takayasu, there aren't any good quality studies, which is reflected in the level of evidence, but still we generally use sort of non-biologic disease modifying agents along with prednisone. I think this is just for you to be aware. I will say that these are kind of complicated diseases, and I think it's reasonable when you suspect the diagnosis to refer them to either internal medicine or rheumatology, but it's good to be aware. And then this part is about monitoring. I thought this needs a little bit more of a discussion. So when you treat GCA or Takayasu, it's reasonable to monitor their disease, obviously, with inflammatory markers, imaging, and clinical assessment. So the one thing I wanted to discuss is inflammatory markers. So they actually are not reliable markers for disease activity in large vessel vasculitis. Especially when patients are on tocilizumab. Tocilizumab directly decreases production of C-reactive protein and pro-inflammatory proteins in the liver. So everyone on tocilizumab has normal inflammatory markers. If their disease flares and they're on tocilizumab, inflammatory markers do not raise. So that's actually a huge limitation about using this medication for us, because that kind of eliminates inflammatory markers as an option for monitoring the patient. Even outside of the setting of tocilizumab, certainly there is evidence that some patients are diagnosed with active GCA and they have normal inflammatory markers, both ESR and CRP. And even in my clinical practice, some patients have kind of low elevation of inflammatory markers at all times, even when they're in remission. And then when the inflammatory marker goes up by 5 points, whether or not it's really quite difficult to interpret that. And others are the opposite. They're always normal, and that elevation is still within normal range. So certainly it's quite difficult to rely on inflammatory markers to decide on disease activity. And that's even more the case in Takayasu's arteritis. In Takayasu's, systemic inflammation is felt to be a manifestation of early stage of the disease before vascular damage happens. By the time vascular damage happens, often inflammation systemically settles down, and then the inflammatory markers become normal despite disease continuing to be active in the blood vessels. Now, in terms of monitoring, so in my mind, monitoring is a big aspect of, in terms of imaging is a big aspect of monitoring of large vessel vasculitis. Ultrasound, we kind of now don't use it as much for monitoring of the large vessels. Where we use it is to diagnose giant cell arteritis. We can now do ultrasound of the temporal arteries and sometimes axillary and carotid, usually for diagnosing active GCA or for diagnosis of flares. For large vessel disease, including aortitis, the mainstay is CT scans. So usually when I diagnose giant cell arteritis, I do a CT of their whole vascular tree to assess for evidence of large vessel disease. MRI is better at looking at the vessel wall. So, and generally it's the modality of choice in the guidelines of Takayasu arteritis. The reason is that Takayasu's, there's lots of sort of structural damage in the vessel with lots of stenosis and so on. And sometimes it takes fine tuning the degree of like vessel wall inflammation to decide, is the disease still active or not? I also use MRI when I have to do imaging frequently to monitor patients, because obviously a lot of CT scans is a lot of radiation. PET scan is becoming sort of increasingly popular. I find that it's too sensitive to be used routinely. It obviously is very good at picking up inflammation, but it also picks up all kinds of things. Let's say if a patient has surgery for, thoracic aortic surgery, that uptake stays sometimes for years after the surgery, and it's quite difficult to decide whether that's, post-surgical or is it active inflammation. Also, so I use it usually to decide if it's active inflammation when the other modalities are kind of equivocal. And then once treatment is changed, or in patients who start on treatment, PET scan takes a while to actually change in the degree of uptake that it's showing. Multiple studies show that, like, when people are starting on treatment, despite there being, the general sense that they're in clinical remission and including in the vessels, PET scan remains positive for quite a while thereafter. So it's not very sensitive to, decreasing of the level of inflammation. So anyway, it's good to use once in a while, but certainly not to the degree that sort of that we would use it routinely. And then some centers have PET MRI, PET CT. I believe we might as well at the Heart Institute, but potentially maybe for research. I certainly haven't had access to those. I imagine those would be very useful modalities. I'm pretty much almost done. So this part actually talks about the fact that if a patient needs surgical intervention, that ideally their inflammation should be controlled first. I do think that it's, obviously common sense, and I think most people will try to do that. I also have some good cases from that I'm sharing with Munir, for example, where we kind of did exactly that, control the inflammation first. We had to sort of prove that it's controlled, and then patient could have surgery afterwards. And then the last part is quite a low level of evidence. As you see, this is expert opinion only, where the recommendation is that once patients' aortitis or large vessel vasculitis goes in remission, they should have annual surveillance imaging. I mean, I think I agree that they should have ongoing surveillance imaging. I think annual to start with is reasonable, but some of these patients are quite young and you're not going to do every year imaging for the rest of their life. I think if they, the changes remain stable for the first few times that they're imaged, it certainly can be spread out. From rheumatology guidelines, there is a bit of a controversy whether or not that should be done. I guess in general, I think most guidelines do say that they need imaging. They sometimes put it as, you don't need to do imaging once they're in remission to look for disease activity, but you do need to do imaging to look for structural damage. Well, if you're doing it, then you're doing it. It doesn't really matter what the reason is. So overall, I do think that once they're in remission, they do need monitoring with imaging, going forward. And I think my last two slides is just to prove that point that this is actually not from our study, but after patients have their surgery, if you follow these patients forward, many patients do end up requiring subsequent surgery or have subsequent events. I think that's probably well known. And interestingly, aortitis actually might require that to a greater degree than the non-inflammatory aortopathies. And then this is a similar point about clinically isolated aortitis. So even though it's presumably just isolated to that area, but following patient forward, there are quite a bit of kind of distal ascending aortic dilatations and events that require subsequent surgeries. And we actually, as Munir referred to, we do have several studies that we've done together and me separately. And many of our cohort patients are clinically isolated aortitis, and we certainly do find that they have sort of subsequent aortic new structural issues that may or may not require surgery going forward. So again, to prove the point that monitoring is required afterwards. So I think that's my part.
Thank you so much for an excellent talk, Dr. Milman. We have time for maybe one question.
I'd like to ask a question if I could. I see a lot of these patients and share them with a rheumatologist or two here. And we work it out, but there's always like a little bit of confusion about who should be ordering surveillance imaging on these people. And because typically I'm following an aneurysm or something, I do it. But, I'm not sure if I'm stepping on anybody's toes or not. What do you think, and how do you manage that? Who should take the lead about organizing the surveillance imaging?
Who should take a lead? I think it's a discussion between the specialties. So in my case, many of the patients, I guess it depends. So in my case, I follow many patients who are also followed by the aorta clinic, because if they had some sort of procedure, let's say if they had an aneurysm repaired or something, or they're being followed for an aneurysm, then our surgery team follows these patients in the aorta clinic. And when they do, they generally take care of the imaging. Having said that, when I see the patients, I usually copy my notes to the surgery and I tell them that I am assuming they're ordering the imaging. If not so, please reach out to me. And so we are in communication. But I also follow many patients that are not also followed by surgery. Usually that's sort of radiographic aortitis that doesn't necessarily look like it might need surgery or something like that. Obviously, in those cases, I order the imaging. I think it also depends on who, eventually someone stays on the team and the other service steps off. I don't know if, then whoever kind of sees them will order. So I don't know that there are rules, and yeah.
Okay, so it sounds very similar. You work it out.
Probably, yeah.
Yeah, okay. Thank you.
Natalia, I have a quick question.
Sure.
For an issue I think we run into not that infrequently. Often we see patients who come in with an aortic aneurysm. There's no real suspicion of aortitis before they go to the OR, but then you send their aorta piece for histology, and someone like John Vino, who's on the meeting I see,
I saw
looks
that.
at this and says it's aortitis. And so then we send them to you. A year later, they have imaging, and maybe it shows some changes in the aorta. They have mild dilatation of a distal segment. I guess what we really struggle with in that context is what is the threshold for treatment? Because now you want to avoid future aortic events. You have a diagnosis histologically of aortitis. We don't really have clear threshold, at least in my mind, of when to initiate therapy, especially if they don't have any systemic marker elevation or any systemic evidence of active disease. I'm curious to know where you think the literature stands or where clinical practice should go for those kinds of patients. There's a number of these individuals that we can follow.
Right, those are the ones that we once in a while then discuss at our combined rounds to decide what to do. So I, as you correctly said, there are no guidelines. So what I usually do is, let's say if there's no systemic process that we identify, and if there's no evidence of systemic inflammation on blood work, then, in my mind is looking, first of all, is there evidence of vessel inflammation on imaging? So either, CT or MRI, do they show thickening of the vessel wall that would suggest inflammation? And then if not, then, PET scan could come in and help, but that would only be more helpful if there was no surgery prior to that. And oftentimes they do have the surgery. But really, so either if there's vascular kind of inflammation that's suspicious on imaging. And then the other thing would be if, there are some expected, like there's an expected rate, I'm assuming, of dilatation of the aorta that's already dilated. I guess we also discussed that, if you see that it seems to be out of keeping of what's expected for a regular degenerative aortic aneurysm, that might be another indication for therapy. I will say that my threshold for therapy is quite high. Therapy is not benign. Oftentimes, I don't want to cause more symptoms than the benefit. And then there's also some evidence that if they actually have an aneurysm and you put them on steroids, there's increased risk of rupturing that aneurysm too. So I usually would need to be convinced to actually start treatment in those cases.
Thank you.
Thank you so much, Dr. Milman.
Thank you.
It is now my pleasure to introduce Dr. McMurtry. So Dr. McMurtry runs the Aortic Disease Clinic at the Manzankowski, Alberta Heart Institute. Where he is an associate professor. He trained partially at UBC, Dalhousie, University of Alberta, and at their Brigham and Women's Hospital in Boston at Harvard. So he will talk to us about medical treatment for aortopathy. So welcome. Thank you.
Thank you very much. I'll just pull up my slide set here. You're seeing it?
Yes, but we're not seeing the presenter view yet.
There it is. I think you see it now?
Perfect.
Okay.
Yes.
Let me just move this one panel out of the way so I can... Perfect. Okay. So here we go. Thank you very much for the invitation. It's really a pleasure to be here today. I have to say that my attending conferences and engaging with people has not yet returned to what it was before COVID, and it's really a pleasure to connect with people again. So thank you again. I'm going to talk about pharmacotherapy in patients with aortopathies. There we go. There's a bit of delay in the slide change, so bear with me. I have no conflicts of interest with respect to the material. I guess technically almost anything we discuss is off-label, and so I'll disclose that. And I'm focusing here on thoracic aortic disease. I think that was the intent. There is a large literature on patients with infrarenal abdominal aortic aneurysms, which are arguably a different beast, a complication of atherosclerosis, and I'm not talking about that today. So I'll deliver the punchline first. Seinfeld was famously a show about nothing. And hopefully this talk will be more than a talk about nothing, but it's really a frustrating area in that we don't have randomized trial data with hard outcomes like acute aortic syndrome or death for any of our patient types. There's a little bit of data that's randomized on Marfan syndrome, which I'll discuss. But it is a wide open field, really. And so a lot of what I'm going to say is based on hemodynamic rationale, epidemiology, and expert opinion. And so I just want to get that out front first. I'm going to talk about these objectives. So pharmacotherapy, what is medical therapy really? And kind of what I'm talking about is what I do in the clinic every day. If you're a medical specialist and you're seeing these patients, it's more than just selecting the pill that you should take for their blood pressure. There's a set of other issues that I think are worth thinking about each time that you see them. So talk about medical therapy, what is it? Blood pressure, CV risk reduction, how we do it, lifestyle management, what I tell people, a little bit about surveillance, and then maybe some gaps and questions that I'm hoping might generate a little bit of discussion. I'm going to personalize this talk and kind of, share my idiosyncrasies with you all and hope that that will generate some discussion or maybe some criticism about what I might be able to do better or whether there are things we need to sort of look at. So what's medical therapy? This is a quote from one of Munir's papers. In both groups, patients will receive optimal medical therapy for their aneurysm according to guidelines. And it's easier to say, but a little bit harder to do. I think there's some subtleties to it. And as I said before, it's more than just selecting a blood pressure medication. The primary goals of medical therapy per the AHA guidelines are to reduce growth rates. We have a little bit of evidence for that. Reduce the risk of aortic-related mortality. We don't have much for that. And then reduce the need for aortic repair. And so those are the main goals. The physiologic rationale, this is a quote from the European guidelines on the topic. Reduce shear stress on the disease segment of the aorta by reducing blood pressure and cardiac contractility. And then there's a secondary goal of medical therapy also, which basically is to decrease the risk of non-aortic cardiovascular events. We're thinking here mostly heart attacks and strokes, but you can be expansive and say it's preventing atrial fibrillation and other problems as well by managing concomitant risk factors and recognizing concomitant atherosclerotic disease when it's present. So blood pressure, what do we know about it? We wrote this sentence in 2014 in the Canadian statement. Randomized controlled trials of antihypertensive therapies have not included patients with thoracic aortic disease per se or reported consistently on aortic endpoints. That's still true. I spent some time this last week doing PubMed searches, and I'm afraid to say that the literature hasn't changed much since then, which I guess we could, as a community, view as an opportunity. But today, in February of 2024, leaves us with a bit of a gap. There are some data about the Marfan syndrome. And so there's a set of small randomized trials, all of which used as a main endpoint as the aortic diameter. So not hard endpoints, just aortic size, basically, and used various comparisons, either beta blocker versus control, beta blocker versus angiotensin receptor blocker, combined therapy versus beta blocker, for example. And so it's very heterogeneous. It's fair to say that the summary of these data are that these agents, angiotensin receptor blockers, beta blockers, and the combination of therapy are effective at delaying the growth of the aortic root in patients with the Marfan syndrome. And these investigators did quite an interesting thing. They did a network meta-analysis, which, if you aren't familiar with the technique, involves making a set of indirect comparisons to try to sort of figure out which agent might be optimal, even when there isn't a randomized trial evaluating all the groups head to head. And so this is the main figure from that paper. Change in aortic root growth in millimeters per year versus control is the outcome. When the comparison versus control, any of these regimens appear to work. ARB, ARB plus beta blocker or beta blocker compared to control. When the comparator is ARB, beta blockers appear to be no better than ARB. ARB plus beta blocker does appear to be a little bit better, and then control is inferior. And this basically just shows the same thing. And so we do have some evidence that in the Marfan syndrome, either a beta blocker or an angiotensin receptor blocker is effective at delaying aortic root growth, and probably the combination is better. I myself wonder if it's not so much the combination as it is the intensity of blood pressure reduction, but that's something that we can have a conversation about. Historically, beta blockers were around first and sort of have formed the cornerstone of therapy in this group, but probably either agent is reasonable. But that there isn't data for other kinds of patients, and so we're left looking at other sources of guidance over and above the physiologic rationale. Some have used epidemiologic data like this. So this is a study of 4,600 non-syndromic adults with ascending thoracic aortic aneurysms measuring 40 to 55. And they looked at predictors of aortic dissection or rupture over time. And so the big predictors were hypertension, age, and aortic diameter in a multivariate model. And so some have argued that this, justifies the treatment of aggressive blood pressure reduction in this group to prevent aortic dissection and rupture. Better than nothing. And then there's this epidemiologic study, which was interesting also. It's a screening study done in Denmark where almost 15,000 men were invited to be screened for various forms of cardiovascular disease. That study overall was negative in terms of making people live longer, but it did show that the predictors for enlargement of the aorta in a given segment were as follows. The most important one actually was aortic dilation in a different segment, but then hypertension, atrial fibrillation, and family history followed as predictors. And, why atrial fibrillation, my own belief is that that's a manifestation of hypertensive heart disease, that if they took that out, probably the hypertension odds ratio would go up. Again, something that we can have a conversation about. Again,
could you please mute yourself?
I'll carry on. Anyway, there's an epidemiologic justification to treat blood pressure in patients with thoracic aortic disease. And so that's what the American guidelines say. It's a level 1 recommendation with non-randomized evidence as the evidence base. And they've chosen blood pressure cutoffs of 130 and over 80, which is based on the SPRINT trial. The SPRINT trial wasn't in patients with thoracic aortic problems at all. It was in patients who were at risk for cardiovascular disease, think coronary artery disease, so patients with hypertension, dyslipidemia, but not diabetes. And that trial showed that intensive blood pressure lowering into the 120s is what they achieved, though they were trying to get lower, compared to sort of more permissive, under 130 over 80. Basically, that increased blood pressure reduction was associated with mortality benefit. And so that's what the recommendation is based on. What about choice of agent? Without much to be based it on, beta blocker is a reasonable place to begin according to the guidelines. And then ARB as a adjunct is also reasonable. I have to be honest here. In my own practice, I don't use beta blockers often as the first line agent in blood pressure. I spend a lot of time in my office trying to convince people to take their medicines, and you often don't get that many opportunities to convince people to get on something. And if you make them feel very tired or miserable, or if you give them erectile dysfunction, they won't forgive you. And so I often will start first with an angiotensin receptor blocker for that reason. And I think that's justifiable given where we are with the evidence base, but I'm really interested to know what you guys think. This is what's said about the Marfan syndrome based exactly on the randomized trial data. that we have. Start with a beta blocker, think about adding an ARB, and this is really interesting in my view. Maximally tolerated doses is what they say. What does that mean exactly? Again, I spend a lot of my time in my clinic trying to get people to stay on medications, and yeah, I'm not sure what to do with that exactly. Typically, I'll get people beta blocked to a heart rate of 60, and after that, I'm not sure what to do. It sort of depends on the patient, I think, a little bit. And then in the Loeys-Dietz, that decision or recommendation is made in analogy to what's written about the Marfan syndrome patients. Again, there's this caveat, maximal tolerated doses, that I think leaves a lot to be desired in terms of guidance for the practitioner. No specific medical therapy recommendation is given for bicuspid aortopathy, Turner syndrome, vascular Ehlers-Danlos, or other forms of inherited thoracic aortic aneurysm, but the suggestion is you treat them by analogy to Marfan syndrome. And so shoot for blood pressures under 130/80, beta blockers first, ARBs second, and maximally tolerated, basically, is what I read into the guidelines as they're written. What do the Canadian guidelines say? I've got to be honest with you, I don't look at these very much because I find them disappointing. They don't say anything about patients with thoracic aortic disease. There's this high risk of cardiovascular disease where the target is to get them under 120. But when you read the fine print, it's they're thinking at risk for heart attacks, basically. And so I'm not sure that this guideline set helps us very much to manage this group of people. Just a note on aortic dissection. In the management of acute aortic dissection section, they say patients should be treated to a systolic blood pressure of under 120 systolic. And then we're kind of left wondering what to do with that when they show up, 3-6 months later. Basically, they reverse events and have this text here. Additional antihypertensive therapy should be added as necessary to adequately control blood pressure without guidance as to what that means. And again, I live in the real world, and what I often see is somebody who's been hospitalized with a type A aortic dissection, who's been put on a lot of medical therapy. They see their family doctor before they see me. And some of the medications have been stopped because they feel lightheaded or whatever. And so it's not clear that I can convince them to get under 120 systolic. And it's something I think about, it's something I wonder about, and be interested to know what you folks do in your practice for those chronic dissection patients. So what's my approach? Everybody gets a blood pressure of under 130/80, no matter what. I admitted my bias already in favor of ARBs over beta blockers based on tolerability. I mean, that's what I'm seeing when I practice. I try to be more aggressive with blood pressure control in patients with genetic aortopathy, and so I have bought in at least a little bit to what the guidelines say about maximally tolerated, but you really can make people feel miserable if you're not careful. And so, I often sort of weighing the pros and cons of going up on therapy. And then, of course, balance the risk of overtreating with future risk for aortic complications with escalating therapy. I'm sure we all have patients who are brittle. Their descending thoracic aorta is dilating now after their type A has been repaired, or they have Loeys-Dietz and they've had a second complication or something. Well, you really want to pull at all the stops in a patient like that, maybe, but in others, maybe that's overkill. And so it's a personalized approach that isn't based on data as much as it is personal experience and a gut feeling sometimes. What about CV risk reduction? My own practice is to think about it in everybody. And so everybody I see, I'm asking about smoking. Again, this is anecdote, but in any subtype of aortic disease, I see aortas grow when people are smoking. And so I try to get them to quit if they're smoking. That includes marijuana. I asked them about that. Aortic atherosclerosis is considered a coronary risk equivalent in the guidelines, and they recommend consider low-dose aspirin when it's present, and then, of course, consider a statin for subclinical atherosclerosis. My approach is a little bit different than that. Again, I ask about smoking at every visit. I use a Framingham score on everybody. Usually the genetic aortopathies that I see first are young and isn't relevant yet. but the bicuspid aortic valve patients or the degeneratives, obviously, they often have subclinical coronary disease. And I think it's a therapeutic mistake to not be really aggressive about those people. I only use aspirin for symptomatic atherosclerotic cardiovascular disease. And so in my aortic clinic, often that's people who've presented with acute aortic syndrome. If I just see subclinical coronary disease in a BAV patient, for example, I often do not use aspirin in somebody like that. And again, I'm happy to be criticized if you guys do it differently. And then I'm often ordering renal function and checks for diabetes because I don't know what Ottawa's like, but in Alberta, often people don't have primary care doctors. So no one else is doing it. So I often will wind up doing it. Lifestyle management, this is what the guidelines say. So for patients with significant aortic disease, education and guidance should be provided about avoiding intense isometric exercises, so heavy weightlifting or activities using a Valsalva maneuver, burst exertion activities, and collision sports. Patients who've had repair should go to rehab, okay. And then patients should be living healthy, active lives as part of management of their blood pressure. My approach is a little bit personalized here. I try very hard to convince people that they should think of themselves as healthy and able. I use those words when I talk to people. I try to get people doing 150 minutes of moderate intensity exercise per week of something that they enjoy. I do tell them about avoiding lifting excessively heavy weights, no Valsalva or straining. They should be able to freely breathe, but I also encourage them to, take in their groceries or pick up their grandchild or golf or do what they enjoy that gives them pleasure in life. Aerobic cardiovascular exercises are generally fine. Avoid contact sports. But I encourage patients, like a lot of men's league guys, to keep playing men's league hockey, just like no checking. And I revisit this permissive approach if an aorta is growing on serial imaging, and we'll have conversations about what they're up to. And it's very rare that I tell them to stop doing something, actually. That doesn't happen very often. And I think people are reassured and feel good that they should keep doing whatever it is that they enjoy doing, golfing or salsa or whatever it is. The other thing that I do that I never read anywhere is include lifestyle as a factor in deciding when to refer for repair. And let me give you a couple examples here. I had a case of a young Indigenous guy from Joe Haven, which is way in the middle of nowhere in the Arctic, hours and hours, like a day's travel from anywhere. He had Marfan syndrome, and he had a 43, 44 millimeter aortic root and was doing things like hunting and what have you. We elected to offer him a valve-sparing repair at a quite a relatively unusually small dimension for that reason, which I stand by as a good choice. If he ever ruptured up there, that might be it. And then I also had a patient who's a bicuspid aortic valve patient who had a 49-ish, 50-ish millimeter ascending thoracic aorta, and the Army wouldn't let him do anything. He was sort of sidelined from his career. And so he's somebody else that we sent for a repair at an arguably relatively low or marginal dimension that I think was a good choice for that patient. And so, again, this is a personal touch that I do in my practice that makes sense to me, but I'm happy to hear what others think about it. A little bit about surveillance and screening, and I mention it for completeness here because often if you're a medical specialist seeing these people, you're the only person that's going to think about it. The guidelines do say a lot about imaging timing, and I'll just say that it's condition specific. And I think, Julie, you already went over that for the hereditary stuff, so I didn't put that in here. So think about when they need to be imaged next. Don't assume the surgeon or the rheumatologist is doing it, but maybe take ownership of it. And then screening. This is what I do in my practice. I do work at a tertiary center, but it's a precious resource, medical genetics. Not everybody can get in to see them. And I don't have the ability in my own practice to do extensive screenings in families. And so in all the patients I see for that patient, I check their whole aorta. For screening of first relatives, I restrict it to the BAV patients or patients with a family history. often you've got patients who it's clear the aorta was big because they were doing cocaine or they smoked for 50 years. And I don't go fishing for other family members in a case like that. But if there's a strong family history or an apparent connective tissue disorder, then it's off to the medical geneticist. So what are some gaps and questions for maybe us to talk about? Wow, we need some trials. Wouldn't that be nice? What blood pressure targets are appropriate? I'm using at least under 130/80, but in selected patients, I'll go a little lower than that. What does maximally tolerated mean? I'm curious to know what you guys do with that. What medication regimen is best? I told you my bias in favor of ARBs, but I'm happy to be criticized for that. And what do you guys tell patients about exercising and working safely? And what's the optimal timing for repair? The more I do this and the more I sort of work closely with our surgical group here, I'm convinced that there isn't one number for one aortic condition, that every patient's a little bit different and it's a fair conversation. And in my practice, I start to have the conversations with the surgical group to make plans for people sooner rather than later. I don't wait until it meets the guideline threshold in every patient along the lines of some of what I've told you. Okay, so we've gone over these objectives. Look forward to hearing your thoughts and answering questions if there are any.
Thank you so much for a great talk. Does anybody have any questions? And if not, I have one. So you mentioned marijuana, and I'm just curious about that because particularly since it's been legalized, in my clinic, I think I now see more people who smoke marijuana than who smoke cigarettes. You mentioned that everybody who smokes in your practice, their aorta gets worse. That's true for marijuana as well, not just cigarette smoking?
That's what I see. I see, if the patients I have whose aortas grow, there's usually a reason. And their blood pressure is poorly controlled is a common one. Ongoing problems with smoking or substance abuse is another. There are some subtypes, like Loeys-Dietz patients, for example. Doesn't seem to matter what I do in terms of medical therapy, their aortas grow, and they're going to have another repair or something. But most patients, if you can manage their blood pressure aggressively and they're not smoking. I guess the other one that I see is morbid obesity. If they're morbidly obese, their aortas will grow. That's what I'm seeing. And I have to wonder if that's in part mediated by blood pressure. But it's anecdote, I guess. But from my perspective, smoking, and it's better if they didn't. I encourage them to use edibles if they must. But again, it's like, I'm not judgmental about it, but I think smoking is unwise if you've got one of these conditions.
No, thank you for that, because there's definitely good literature on cigarette smoking, but there's a paucity of literature on marijuana smoking. So I think that it's definitely an important message. Thank you. You asked about what does maximum tolerated dose mean, and I'm not a cardiologist, so I won't teach you about that. Angiotensin receptor blockers do have a role in remodeling of the media of the artery at fairly high doses, like 100 to 150 milligrams a day. So for patients for Loeys-Dietz, for example, a lot of physicians will like them because of that additional effect as well. But I agree with you, a medication that you take is better than a medication that stays on your nightstand or your counter.
Yeah, absolutely.
Munir, you have your hand up?
Yeah, I have a question. And Sean, that was a fantastic presentation, as always, very thoughtful and data-driven, but also very practical. So thank you for that. I have two questions. One, just to get your insight on how you do this in Edmonton. What is the standard for blood pressure monitoring in your patients? Do you use the office blood pressure measurement? Do you ask your patients to keep a blood pressure diary of some sort? Do you do ambulatory, 24-hour BP monitoring? What is it that we should be titrating to? That's one question I have. And then the second question is, I think you very clearly laid out that one of the things we really need in this area to advance medical therapy is randomized trials in aortic disease. And I think you're aware that we're trying to do, that very thing through the Titan network, looking at surgery versus surveillance. And we have actually a fairly large cohort now of multi-center prospectively followed patients in whom RCTs could be considered. The question, I guess, to you would be, if there was one question that you think is the most useful, the most, the lowest hanging fruit for us to try and answer through RCTs, is there one that comes to your mind that would be the most impactful?
So in terms of monitoring blood pressure, again, I live in the real world, and by the time they get to my office in the Mass, they've had to fight traffic, they've had to find parking, they're kind of stressed out to see me anyway because I'm going to talk to them about preventing heart attacks and strokes, and maybe they need surgery again. It's always higher in my hands in the office than it is in the community. And so I examine patients and I do like serial 5 or 6 measurements of blood pressure, but I often will get numbers that are much higher than what patients are telling me they get in the community. The other thing that nobody ever taught me this, but I do quite a lot, is I often will have echoes or MRIs that will tell me about the thickness of the ventricle, whether or not there's LVH. And so I pay a lot of attention to that. And so if I'm seeing LVH, I'm pretty sure their blood pressure control is poor and will do more. But I try hard to get my patients to take ownership of their blood pressure, be taking it regularly. And I tell them that they don't need to be neurotic about checking it every day or moment to moment. But if a month goes by, they should have half a dozen or a dozen measurements so that they convince themselves that they're reliably controlled, routinely under 130/80 or whatever it is that we want. And so that's what I use. It's too much of a hassle to get ambulatory blood pressure tests on everybody at our center. And so I don't. I go by what the patients tell me and whether or not there's LVH. And then in terms of a trial, I think probably a blood pressure goal and whether or not that impacts aortic pathology somehow, like more than just dilation, but time to surgical repair or growth rate or something like that, just because mortality would require a lot of patience.
Fantastic. Look, I think we should have a follow-up conversation, Sean, just to see how we can leverage Titan to maybe achieve that objective. Possibly, maybe I'll connect with you offline on that.
Sure, it'd be a pleasure, and thank you again